Okay, you should be able to see that. I'm just going to make it bigger. Can everyone see that okay? Thank you. Okay, so very quickly, I'll give you a little bit of background about what it is, what it is that we want from you, and a little bit of background from the research that we've already done in terms of the barriers to surgical reconstruction. I think, listening to some of you echoes the words in our survey. So I think you'll be very familiar with this. So I guess the question is, what should the NHS care pathway look like for referral for surgical reconstruction of a severe pressure ulcer? Now, some of you, if not all of you, have completed the first survey that we sent out. And this survey was sent out to 137 nurses and 43 surgeons. The survey, people who completed the survey left a lot of free text comments. So, and we actually analyzed this using thematic analysis. In other words, we grouped those comments into themes. And these are, I've got a summary here of the main barriers to referral that you have listed in the free text comments. And some of you, as I said, have echoed this already. So very briefly, there are no clinical guidelines to tell you who you should refer. There is no MDT approach to care. Surgical units do not accept patients, and this has been very clearly echoed by some of you today. There are no care pathways that connect primary, community, nurse-led care teams to secondary care teams. You've got a very heterogeneous population with different primary conditions and under different specialties. There seems to be also reported a lack of knowledge of where and how to refer patients for surgical reconstruction. Some of you said there's no adequate post-surgical care and support, so therefore you don't refer. And as you can see, all those barriers, the ones in blue, are largely to do with a lack of pathway. And some of you listed patient factors as a barrier. So, for example, patient comorbidities, high-risk patients, adherence factors and preference factors, because some patients, of course, do not want to travel out of area. So this next diagram, I kind of put together a kind of pathway and the things that ought to be considered for a pathway in terms when you're starting out designing a pathway. So the first of these are criteria for selecting patients for surgery. And I've given you some idea of what these criteria might be. And just to say that this is what we will be covering in the second part of the consensus. So we'll be going through these factors and you can decide, which of these are important or not. So, that's something that we will do today. The second issue is preoperative optimization. And again, I've given you some ideas about what might need to be optimized. And we would like you to kind of have a discussion or tell us, who should be doing this and how this should be done. Now we have there, the third point is operative procedure selection. Now, there are no surgeons here, but we will have a consensus process with surgeons at some point in the future. So I've left that in there, but obviously we won't discuss that today. And then we've got post-operative management and what this should look like. And again, some examples there. And then patient education and psychological support. So what happens after surgery? Now, the main points that we're interested in covering today are the first two. So criteria for selecting patients for surgery, how do we select patients for surgery, and how they should be optimized. So in other words, just increasing the number of people that get referred. I guess I know that a lot of some of you have made comments about post-operative management and that there isn't the support in place that you need for that. So sometimes that can be a barrier to reconstruction. But I think today we want to focus on what can be done to increase the number of patients being referred for surgery. So this is going to be largely an open discussion because we felt we are not in a position, because none of us are clinicians, to design this care pathway. So, we could have designed it and got you to kind of vote on various aspects of it. But actually, we felt that it's probably better that you design it, that you tell us what it is that you need. If we have time at the end of the meeting, I will collate the main features that you bring out, and we will vote. I will ask you to vote right at the end. If we don't have time, I hope you don't mind that after this process is over, but very quickly after, so ideally this week, we will be sending you a very short survey so that it'll be on SurveyMonkey, no more than 5-10 minutes for you to vote on, whether you agree or disagree about the main aspects of the pathway. So the first question is that I would like all of you to consider is, how do you currently refer patients for surgical reconstruction? I actually feel that some of you have covered that in your introductory talk very well. So maybe we don't need to repeat that. But I think the important thing is, what should the care pathway, so question number 2, what should the care pathway look like for referral for surgical reconstruction? So again, bearing in mind that we're looking at this sort of pre-operative side of things. Now, to give you some idea of where we're kind of coming from with this, and what some of your comments in survey 1 are all about. So everybody who responded said they would like a commissioned service, and the lack of a commissioned service is a big barrier. Virtually everybody also said they wanted some kind of MDT. But, what we would like to know, what should this MDT look like? Who should it have in it? Can it be remote or virtual? Can patient wound suitability be assessed in this way? Or would you need to visit the patient? Should it be done face-to-face? Who should be making decisions about, for example, patient suitability for surgery? Would you need some kind of checklist for screening a referral for preoperative optimization? Who should be doing it? Do you need some kind of somebody to tell you about the quality of skin muscle for reconstruction, for example, or do the surgeons do that? Or are you, all of you, doing that already, or are capable of doing that? How do you assess, or should you be assessing patient motivation, ability to adhere to postoperative care protocols? How should it be done? Now, I just specifically wanted to mention something called the Pressure Ulcer Intervention Service, Prevention and Intervention Service, PUPIS, because a lot of people mention this as a kind of ideal service in the pathway, which really facilitates the pathway, really facilitates patients being referred for reconstruction. So this is a service that was set up in Swansea, and it has certain features such as home nurse visit to assess the patient, service that is tailored to individual patient circumstances. They will ensure that all conservative treatment strategies are tried, so that when patients get referred to the surgeon, they've kind of been through everything. They've got, tissue viability nurses, physiotherapists, they refer to tissue viability nurses, physiotherapists, dietitians. They optimize risk factors. And the comments, particularly from the surgeons, is that we get the right patients referred for surgery. So the patients, they are happy when somebody gets referred via PUPIS because they are the right patients for surgery. So these are the kind of issues that we want to talk about. But I guess I'm going to now open up the discussion. And if I can just go back to this question. So I think it would be good, actually, I'm going to shut this down because this is the end of my presentation. What should the NHS care pathway look like? How would you like it to be? So if I can stop sharing, because please do tell me if you do want to have the slide on to give you, to kind of prompt you, but otherwise, I'd like to open it up for discussion. And starting from the beginning, from that very first sort of point of you think a patient is suitable for surgery, what should we do? What should it look like?
Jackie, I can see that you've got your hand up.
Just a quick one to say, we're currently writing the clinical pathway for patients for patients at risk of or with pressure ulcers, and we will be putting in there that for a patient with a category 3 or 4, surgical review should be considered. So I think that's an important first step, that in the standardised pressure ulcer pathway, it's important that we include that for any patient with a category 3 or 4, somebody actually thinks about, should there be a surgical review?
Thanks, Jackie. And I suppose this is dovetails with that in terms of how might that be facilitated to happen, I guess. So, oh, you're on mute.
Sorry, I'm just taking myself off mute. Yeah, thank you. And I'll try and lower my hand as well while I'm at it. Yeah, so just a thought that identifying the cause of the pressure injury in the pressure ulcer to start with. And making sure that the cause has been addressed and removed. So part of the pathway is a good question about who should make that decision about whether a patient is suitable. But we all know that if we don't remove the underlying cause and why they got it in the first place, then and know that we've addressed that prior to surgery, then it's all going to go wrong for that patient again. So somebody else mentioned they had a pressure mapper, and I think we do have 2 pressure mappers as well, hugely expensive but invaluable, to try and work out why patients have, if they've got hot spots of pressure in their equipment. I think that's a really key bit, and then the other bit about whether the patient is willing to offload and follow the advice. But otherwise, I really feel that if we've looked at those 2 bits, that patients should be referred sooner rather than later, because if we sit on them, they end up with osteomyelitis and a bigger problem. So what does that pathway look like? It needs to be quite slick for patients, I think, and have those bits addressed. And does it need to be a specialist, like a tissue viability nurse and service to look at those bits, so that's assured before they're referred on? Just some thoughts.
Thanks, Sue. Aisha.
There were so many questions there. My head was buzzing, thinking, where do I start? So lots of thoughts, really. One of them was around the location of the pressure ulcer, and are you defining that? Are you talking about sort of ischials and sacral area specifically, or is this going to be broad? So I didn't know where you were thinking in terms of reconstruction, whether you were going to focus down a little bit more because vascular might be involved in other services, etc. That was one thought. The other thought was around, I guess, the diagnostic side, which some of us have talked about already, and if there is osteomyelitis present, whether that's acute or chronic, and whether that's going to be addressed, whether it's antibiotics or whether it's surgery to address the osteomyelitis. And again, if it is surgery, that could alter the posture of the patient. One of my biggest team members that I really need on board is the wheelchair services, certainly if the patient is wheelchair bound. So certainly I'd be involving them to look at sitting posture and also to look at the equipment that's used. So they would be a key part of my MDT. And then we've all talked about sort of the adherence concordance side of things as well. Another thing really, again, is the expert patient as well. And I think the patient's voice around the choice of what those interventions may be, because some may opt for conventional dressings, some may opt for surgical. So I think the patient voice needs to be sort of definitely part of that pathway as well. Thank you.
Thanks, that's great. And Jackie, you wanted to come back in?
Yeah, just picking up on a couple of things that have been mentioned. I think timelines are really important, and with any other wound, we can look at what we perceive as a good trajectory. We kind of have a vague idea with the venous leg ulcer of when we'd expect it to heal. And I think that's one of the real weaknesses in the pressure ulcer literature. There is no guidance on what's an expected time or an average time. So it doesn't help us with, if we say, are we delivering good quality care in the first place? This wound appears to be healing. What point do we judge that that's okay or not okay? I think the other element is about the review of the care that's been delivered. I've just marked a master's thesis from an occupational therapist who works in a service that have a pathway for supporting patients with pressure ulcers in wheelchair services in delivery of cushions. But actually, when you look at what the service does, they basically post a cushion out to the patient, and there's no review of if it's appropriate for the wheelchair and if it's the right one for the patient or what the outcomes of that are. So I think we need to be really careful in that initial review about making sure that the interventions that have been given are personalised or tailored to that patient, and particularly to that patient's problem. And from the RCAs we've been involved in, you know, I'm sure you've all found the same. The answers are always the same. It's always about education, it's always about equipment, it's always about communication, but never anything really specific about that individual patient, which tells me they haven't found the cause. So what I'd like to see is a real push to investigate for that patient, what is the problem? Not these generic things. What is that patient's problem?
So can I just ask you all, because thinking about, okay, so if we want to do research on surgical reconstruction for pressure ulcers, we need pathways that allow patients access to that treatment. So I guess I'm interested in whether some of the things you're talking about here are general pressure ulcer care or a part of a referral pathway for surgical reconstruction, in that they're an early part of that pathway that should be available to all patients. Is that what you're suggesting?
Thanks for pointing, Jo. I think unless you've got that right, unless you know you've done the right fundamentals, why would you consider referring the patient for surgery?
Okay, so hold that thought, because I'm really interested in then what comes next. But I want to, Inez and then Claire have both got their hands up. Inez first.
Oh, hi, thank you. I think I just want to reiterate what Jackie said. I think it's very important from the beginning, try to understand which patients are going to have that support. Is it something we're going to offer all the patients as a standard from the beginning? And I think one of the main important things is involving the patient. So we need to find out why the patient has that wound, what's causing the wound, and what's delaying the wound healing, to try to understand what's process, because it can be varied. It can be from the patient is very frail and it has to do with malnutrition. The patient has, as we mentioned before, has to be seated in a wheelchair for long periods of time. But I think if whatever pathway it's decided, it needs to involve the patient from the beginning, because I had issues, for example, with pressure ulcers as well, that the options were not explained to the patient in the beginning. And then when the MDT has a meeting, they reach a conclusion, and then the patient says, I don't want that plan. So I think it's very important from the beginning of the pathway, the patient or the carers, depending on if the patient can speak for themselves. That's going to be another issue in terms of consent and how much the patient can be involved. But I think it's very important to involve the patient from the beginning, for them to understand what options they have and if this is the option. Because again, we don't want to sell it as a miracle option for the patient, that they don't have to be involved and there's no extra care after the surgery, because that's also an issue that we see. A lot of the patients think, oh, the surgeon is going to close it, the plastic surgeon is going to do a very good job, it's closed, and then I don't have to continue to follow the guidance that I need. And then that's when you'll have complications. The patient is going to sit on the previous wound area. They're not going to follow the previous recommendations, depending on why the wound appeared in the beginning. So I think involving the patient from the beginning, and patient education, it's what I've seen, it's always very important in terms of even something new, or even just explaining the different options that the patient has.
Thanks, Liz. That's really interesting, really useful. And Claire, I know you were next, and have some points to making, because I know that you are sort of operating with an MDT. I'm really interested, I think, and this might be part of what you're going to talk about, because in some of the responses, I've heard the word we'll make this decision, we'll do that. And I guess I'm really interested as well in thinking, who is the we in this space? It's obviously the patient, you said, Inez, and the nurse, and who else in this? And we've heard about wheelchair services. I guess in any pathway, thinking about who the we is, it would be interesting. But Claire, I'll stop talking.
Can you hear me okay? Yeah. I think I'd agree with what Jackie said. Quite often we haven't got we work as an MDT, but slightly in silo, and it's myself and my nursing team that are trying to make it an MDT by involving everybody, but what we'd really like is for this team to be established, you know, like what we're going to talk about is what does this MDT look like. But what I have found with my experiences is that we referred patients into our service for review of pressure ulcer reconstruction, and I've been quite alarmed around the level of lack of coordination in their care before they even get to us. And I think that if we're looking at future pathways or referrals, and this is maybe what's put a lot of plastic surgeons off in the past, because X and Y hasn't been crossed, they haven't been pressure mapped all the time. And I know, listening to some of you tissue viability nurses, you've got a great setup with the pressure mapping, and what we're, as plastic surgery nurses, we're going out to make that first assessment and liaise back with our plastic surgeon, but we're quite surprised to see the lack of joined up thinking and joined up care, and we don't even discuss it with our plastic surgeon for quite some time, because the foundations in pressure care is not being achieved, and lack of patient education. And I think sometimes services think that surgery is the solution and a quick fix. And sometimes we do feel like we're going in to bring a bit of bad news, that we need to look at, you know, surfaces, how long you sit out and everything like that first. So I think that patient selection of who needs to be referred in, there should be some criteria first. Have they had nutritional screening bloods looked at? What's the concordance? Are they willing to have a period of time on bed rest? And like you said, if we're going to repair the pressure ulcer and then they're going to carry out the same lifestyle which started the pressure ulcer, is it worth considering it? Now, we have undertaken 2 surgical reconstructions on patients because of representing with a pressure ulcer in the same place, but the 7 or 8 years between pressure ulcer number 1 and pressure ulcer number 2, they've had a great quality of life. So I don't think we should not consider it if they've had it repaired once already. So
Thanks, Claire. Nikki.
Hi, I think so from the work we've done in Cornwall and in Somerset and Torbay and Plymouth on the PROMISE study and using pressure mapping, I totally agree with what everybody said. And there, in terms of using the pressure map, that engages the patient, you get that patient empowerment, you get the patient education, their decisions as to what they want to do and how they want to move forward. And I think we also have to be realistic about adherence, because at the end of the day, these people have also got to have a life. And the pressure ulcer started because something was wrong in their life. And that's either usually their posture or their equipment. Yes, it is potentially their lifestyle, but that lifestyle is unlikely to change. So if we can find a solution using pressure mapping to those other issues, because they haven't had that MDT involved in their posture management and their wheelchair and their static chair and their bed and sleep system and all of those things, then we need to get that sorted to be able to move forward with that surgical reconstruction, so that when they've had it, what had happened previously has changed, so that they can continue to live a normal life and the life they want. And I think that's really vital, because otherwise patients don't want to engage, because we're going to restrict what they're able to do after the surgery. And we know from the research that many patients, it's not the worst thing that's happened to them. It's this, you know, the spinal injury is the worst thing that's happened to them. So unless they can smell the pressure ulcer, actually for many spinal patients, it doesn't worry them that much. They live with the pressure ulcer because it's not impacting on their life in the same way that we think it would do unless they get sepsis. So I think it is about getting that patient buy-in and that patient empowerment, and being able to see those pressure points on the pressure map is really, really valuable, and has a massive impact on the patient's recognition of the pressure.
Thanks, Nikki. Jackie?
I was thinking about a couple of things that have been said and trying to think how I could pull those things together. And I think it's particularly thinking about where risks and causative factors should be modifiable. And I would include in that some of the things that Nikki said about the patient's willingness or ability to change. If something can't be modified, and that's part of a causative factor, then you really need to think about what you're going to gain from surgery. So for me, one of the entry points to the pathway, in that everything that Claire described about have the standard things being done, you know, the things that should have been done, are they done, is then about identifying those things that can be changed. Have those been changed? Because if they haven't, they should be your first port of call, because surgery for a lot of people is a very drastic thing, and it's a very risky thing.
And yeah, and that's, I think that's really, so we're here, I'm hearing really strongly, and Susie, I'm aware, and Nikki Richardson, she's dropped out, I think, and had her hand up as well, that it's really important to get these patients need input to make sure that their current care is optimized, and to involve the patient in future preventative activity and treatment as well, and that's incredibly important, I guess. Well, Susie, I'll let you come in.
What I was just thinking, we identified lots of problems, but who will take the lead on it? Probably as a tissue viability nurse, we know these are the issues, maybe mobility issues or the comorbidity, all those things. So we probably have to take the lead on to refer to the surgeons after identifying the issues. And then we know the patients, whether the patient is suitable for the surgery, whether they are willing for the surgery, and if we need to optimize something, where we're able to optimize their issues, nutrition or their health habits, all those issues, whether we were able to do it. Otherwise, I don't think anybody else will take that lead to refer to the surgeon. That's what my opinion.
Yeah, and I guess I'm interested because I think we all agree, in an ideal world, people would be managed in a way that the majority of people wouldn't get such severe pressure ulcers, and then there wouldn't be a need for reconstructive surgery. I guess part of what we're thinking about today is thinking, okay, if all of these things have been put in place and there was still a desire to consider reconstructive surgery, who would be involved in making decisions about that? Maria, sorry, you've got your hand up. And
sorry, I know I'm mute. I just realized I'm muted. So I'm going to ask some very simple questions because I'm just typing away, you know, this interesting information that you're giving me. But I'm completely non-expert, non-clinical. So some of my questions may be really silly. So the initial review of patient is what I have here as kind of point number one. And we've obviously talked about doing various things like pressure mapping, identifying the cause of the PU, making sure that the wheelchair is fine and the cushions are fine and everything else. Who should be doing this? Who's doing this? It's not clear in my mind. Who is it that is going to be doing this? Who's going to do the initial review of the patient?
Sorry, I didn't see whose hand came up first there. I'm going to go in order of my screen. Nikki, not Kimpton. Nikki Kimpton. Sorry, Nikki.
It's fine, honestly.
I need to move on.
No, it's fine, honestly. I would just like to sort of clarify the difference between pressure mapping and pressure monitoring. And lots of wheelchair services and seating assessments do pressure mapping, which is only half an hour to an hour. But the difference with pressure monitoring is that you're monitoring that pressure over time, and you're looking at somebody's 24, 48, 72-hour lifestyle, because how they sit for half an hour is completely different to how they sit for 4 hours. So I think it's really important that we look at the difference between a pressure map and a pressure monitor in terms of doing that. And I think when you're asking Maria in terms of who should be doing that, I think so wheelchair services in Cornwall do pressure mapping. They don't do pressure monitoring. And I think when we've pressure monitored a patient in a wheelchair for longer than that half-hour period, we've seen a massive difference in their posture over a period of time, because they haven't had the back support, or, you know, they get tired, and they're the conversations that you can have. So, but I do think, and that I think needs to be done in a patient's home, because a clinic situation, you're never going to get a true picture of what is reality for that patient. And at the end of the day, that's what we're looking at. Sorry, my cat just walked into the room and obviously agreed with me because she meowed at the right time. So I think, and I guess when it comes to who should be doing that, it's about who has that skill and who has that level of knowledge and competence, and it does take time. So you know, it's about that input as well. But I do think that should be an MDT approach, because you all have those different skills in posture and in equipment selection. So I think it should be people with that level of knowledge and skill, whatever discipline they are, as long as they have that level of knowledge and skill in posture management, and then, you know, what will happen in that surgical reconstruction, and to be able to make those decisions with the patient.
Thanks, Nikki. Jackie.
Maria, I think your question was about who should be checking that those things had been done, as well as who should be.
Absolutely, you've just taken the words right out of my mouth.
And yes. I think the challenge at the minute, who should be checking those things should be done, is often a community nurse, because they are the primary carer for the patient. So if we're expecting that care to be delivered, the person that will be checking that it's done is the community nurse. So she or they will be checking that the patient is at risk, what level of risk they are, that referrals have been made, that TVN's involved, that, you know, is the patient sitting on the wheelchair, because they're the one that is going in on a regular basis. It's a different question about who should do a shakedown of that review. So who should go in and say, before we make a referral to the plastic surgeon, let me check all this has happened. So which element of that question are you asking on a daily basis, who assesses what's been done, or who should be the gatekeeper of, has everything been done, and has it been done properly before we make?
I guess both. I guess, you know, because there clearly, you know, as I said, I know nothing about this, but there seems to be that there's a problem in the pathway before the patient gets to the surgical reconstruction stage. So in other words, it's very difficult to design a pathway for surgical reconstruction if you haven't got the actual treatment management sorted out. And I assume there is a pathway for that. So I guess the answer is, you know, both.
There isn't a pathway, which is one of the problems, but I think it's because the majority of the care is managed by so many different community nurses. It's not coordinated. And I think what Claire was identifying, that nobody takes responsibility. A different community nurse goes in every day, and although somebody might write a brilliant care plan and trigger brilliant care, if they don't go back regularly, that doesn't get followed or chased up, and it falls to pieces. Referrals get made, they don't get followed up, and people just forget, and weeks become months, and, you know, suddenly the patient's had the pressure ulcer for 2 years.
Inez, did you want to come in?
No, just it was more or less what Jackie already said. So in terms of community, we usually refer our patients, and then they will only contact us back if there's any questions or issues. So we lose a bit of a track of our patients because we work in private, but during the inpatient stage, some of the patients will stay with us because we have some specific wards for rehabilitation. So we will have patients that are inpatients, or they will come as outpatients for physiotherapy or other therapies that they might need. for long periods of time, especially the patients from overseas. So in those situations, that type of assessment, continuous assessment, is again done by the MDT. Unfortunately, we don't have, for example, plastics clinical nurse specialist, so everything falls under tissue viability. So if there's any questions or issues, it will be between ourselves, the physiotherapists, the consultant, and the occupational therapist. So this will be an inpatient, but the patients can come also as outpatients. In terms of community, we lose a bit of a track of what happens unless the patient, the relatives, or the coordinator of the community area where the patient is they will contact us directly, the tissue viability team. So as inpatients, usually it's the tissue viability nurse that tries to bring everyone together from the different teams. But again, there's not a formal plan. Basically, we do it like someone else said, because we deal with everyone on a daily basis. So we try to to be the glue between everyone in the MDT, but there's not a clear pathway as well.
Thank you. Andy.
Thank you. I think it occurred to me just that there's quite some similarities between other different types of surgery as well in relation to bariatric surgery, because if a patient was proceeding to bariatric surgery, there'd be quite an awful lot of inputs that would be needed to that patient prior to them actually proceeding to surgery. The pathway needs to be something similar, whereby all of as everyone's already suggested, that there's lots of things that need to happen for a patient to be considered for reconstructive surgery for pressure ulceration. Exactly in the same way that a patient would be proceeding for bariatric surgery would need to go through lifestyle changes and preventive treatments before they would consider the same thing. So the pathways could be a similar kind of a process.
Thanks. That's a really useful, interesting point, actually. Thank you, Andy.
So can I just ask, just picking up on that point, so for bariatric, if you're having bariatric surgery, I suppose you're going to be referred, you're going to be told you need to lose weight, so you're going to be referred to a dietitian, nutritionist, and presumably you're saying the same thing should happen. So you find you're going to assess a patient, you're going to screen them, you're going to identify the causes of the pressure ulcer and the risk factors, and so then you would be referring that patient on to the appropriate services. This is what you're suggesting.
Yeah, because it wouldn't be the bariatric surgeon that would be the first person to see the patient when they referred in for that surgery. It would be the bariatric nursing team who've got the skills and knowledge and capacity for onward referrals and further linkages to get the patient to where they needed to be prior to surgery actually being considered. Very similar kind of thing that we're talking about here.
And do you feel, apologies, I know Aisha, you've got your hand, do you think there should be some kind of a checklist, some kind of protocol for doing that? I mean, would that help?
Yeah, absolutely. Otherwise, you're just wasting the surgeon's time. Because, I mean, the other thing that I'm thinking about is there's some surgical barriers to, if we just accept that pressure ulcers heal, and most of them do, if we get the patient's conditions right for them to facilitate their own healing, then the surgeons are currently correct in not offering reconstructive surgery for those patients who've got pressure ulcers in general, because it's an additional risk that the surgeon's going to put himself and the patient under. So those criteria whereby the patient would be considered for reconstructive surgery would need to be very, very specific, and the patient would have needed to explore all of the other options, because otherwise why would you put yourself through risky surgery with the potential requirements that you need to have for healing secondary to reconstructive surgery. But thinking onwards, it just so much depends on so many of the factors, because if you have a nasty pressure ulcer on your elbow, that could be relatively quickly and easily reconstructed with plastic surgery. However, difficult to heal a wound on an elbow normally because of the movement in the skin. So there's so many predisposing factors.
Aisha.
I'm just trying to pick up some of the earlier information that Maria was asking. So in terms of if a patient is in a community setting, the standard would be that the community nurses would do a holistic assessment, and that would include screening, risk assessment, nutritional assessment. So part of that initial assessment incorporates lots of things that should trigger referrals to other specialists. To hit the referral criteria for tissue viability, we would also expect that certain things had been done prior to being referred to our service. So a lot of that background work should have already been done. The tissue viability nurse would then pick up what has been done, what hasn't been done, and try and coordinate and set down the correct pathway of management for that patient.
Sorry.
Sorry, you go, Maria.
So presumably that's not happening at the moment. So because this is one thing that the comments from the surgeons reflect. We don't get the right patients referred to us. Is that a fair comment from the surgeons, in your kind of opinion? No.
Sorry, are you asking me? I think a lot depends on the referral process and the screening that should have been done prior to the referral. And if the standard can be met for that, appropriate referrals would be received. So I think if a standard is set, that will help refer the correct patients on. So it's that standard, which is
Sue,
correct.
I think, thanks, Isha. Sue, I think you wanted to come in on that.
Yes, thank you. So there's a couple of things. The one experience of this young chap who was referred to us to the tissue viability service. It must have been 8 to 10 weeks after he'd developed his pressure injury. He was being managed by the practice nurses, and we got him straight into a tissue viability bed. Lucky enough to have one tissue viability bed. We got him straight in there, offloaded. It was deep already. We used larvae to debride, a couple of applications of larvae to debride, and we got vac therapy on. So once he'd come to us, we acted really quickly, and he appeared to be healing beautifully to start with. It was coming up, and then it became a sort of sinus, and you just know then that something's not right. We'd already asked for an MRI and it had been declined. I pushed for an MRI, and sure enough, he had osteomyelitis. So despite all the right things happening for this guy, he still developed osteomyelitis quite quickly. And one of the plastic surgeons that I've had conversations with since say that if you have a grade 4, or even if a grade 3, probably is a grade 4, just hiding, as soon as you've got that depth, then you're going to have bacteria on the surface of the bone, and it's very likely that that patient's going to develop osteomyelitis. And that's why I sort of feel that we need to get these patients seen really quickly, either to get in before they develop osteomyelitis, or, so in my brother's case, they cleaned off the surface of the wound, even though he was picked up really quickly. They cleaned off the surface of the wound before he did the construction. And so that's one thing about acting quickly. I think that it won't necessarily heal if once it's a deep wound that goes down to bone. And the other thing, our experience of our community nurses, they don't have the expertise to tick all these boxes, we tend to find. And so I think they can start, and some of them do have more experience than others. But if it's managed by a tissue viability service in the community to help tick those boxes in terms of pressure mapping and equipment and lifestyle and nutrition and all that sort of thing, I suspect if we leave it to community nurses to tick those boxes, we might not get a really thorough assessment of the patient. I think it needs to come to an expert or specialist at some level if that checklist is going to happen before the referral's made.
So community nurse, TVN should be doing the initial screening, obviously in communication, prior to the referral. Is that's
I think so, yeah. Can I get what everyone's saying about, we just referred everyone to the surgeons, some of them wouldn't be appropriate. So to doing that checklist around the actual cause, can we remove the cause, or can't we? What is that cause? And is the patient willing to have that post-surgery offloading and maybe make changes to their lifestyle if that was part of the cause, and the nutrition and all that sort of stuff before they get to the surgeon?
Okay, so another really silly question, possibly.
Just Maria, just before you come in, can I just let Claire come in?
Oh, sorry, I'm sorry,
Claire. No, that's fine. Just to finish this point before you move on.
We as specialist nurses, we now screen all the referrals that come to our department for consideration of pressure ulcer reconstruction. And it's clear from the referrals that we receive, the GPs have a real lack of knowledge, and you can tell it's been written after a telephone conversation with his tissue viability nurse, and most of the time we get little information on there. It's a paragraph. This lovely gentleman has got an ischial pressure ulcer for the last 18 months. Could you consider him for pressure ulcer reconstruction? And this is where, if those screening and all those care aspects have been ticked off, nutritional bloods, and that information came to us, it's much easier for us to get involved and act quicker, because what I find is we're using a lot of our time filling those gaps before get to us. I don't even speak to our plastic surgeon often enough, and for a long time, until we've dipped to the bottom of it. So I think there's a real important interface there about having the right information sent to us.
That's very interesting, Claire. Andy, I'm assuming that's a legacy hand. Did you want to come in again?
No, I just can't figure out to put my hand down. I don't actually have a little hand button on my screen, so I did it by Alt-Y.
Did you?
Yeah, and very weird. So I don't have a hand raising.
Oh, no, it's gone. It's gone.
There you go. So Claire had a hand up, like a physical hand up earlier on. I think if you press Alt and Y, then it raises your hand, and press Alt and Y, it raises it down. But I don't have an indicator, so I have no idea whether my hand's up or down. So apologies.
Okay. No, it's fine. I just wanted to check.
Tab.
I just wanted to check. So Maria, sorry, I interrupted you.
Well, I'm trying to tie in the MDT to this screening, the initial review. So does the MDT happen afterwards, once you've collected the information? Does it happen, is it part of the same process? Does it happen before? Sorry, silly question, but I need to get absolutely clear in my head.
Claire, and then Jackie.
I think there needs to be two. I think there needs to be a community-led MDT where all the services are involved. OT, pressure mapping, what Nikki was saying. That MDT needs to happen before they get to us. And then based on that information, we then have our surgical MDT, plastic surgeons and our microbiology department, and then we base our MDT based on the information given to us. So I think there needs to be two different.
And that answers my question very clearly. Thank you very much.
Jackie, did you want to come in, or was that?
I was going to say exactly the same as Claire.
And Maria, do you need any more information about who might be in each of those MDTs?
Yes, please. No, I've got yes. So surgical MDT, if I could have some bits of information. I mean, you will all get to see this, by the way, and be able to add to it. So we've got microbiology, plastic surgeon. This is plastic surgeon, assuming that if you are in a plastic surgery unit, but it could be orthopedics, it could be whatever.
Claire, who's in your, put you on the spot, so don't feel like you have to answer this. Who's in your MDT at the moment?
Unwillingly.
Yeah, even if they don't want to be, and they might not know they are. But...
an orthopedic surgeon and a microbiology, and we work remotely via email. But I think one interesting point to know is that is that plastic surgery over the last 10 years, it's become so specialised that they branch off and do their own things, and pressure ulcers are a very generic surgical kind of niche, if you like. So I think that's why we don't have as much input from the plastic surgeons anymore, because it's been a generational shift, and a lot of the younger plastic surgeons now haven't had the exposure or the experience. So I think it'll be really interesting when you meet with the surgeons to get their opinions of this.
And could I just ask then, so for the community-led MDT, we need obviously the community nurse, we need the patient carer, we need the TVN, anybody else who might be in the MDT before the referral to other services?
Need the GP as well.
Okay.
I would say for the surgical MDT, you should have the medics as well, because they would be looking after them from a medical point of view to make sure that they're fit for surgery. Yeah,
so the anaesthetist and all that.
Aisha, is there, you put your hand up, I know when the members of the MDT were being talked about for surgery.
Just to include the dietitian, I think Maria mentioned that, infection prevention and control.
Is this for the surgical MDT? Surgical or the community MDT?
Both, really, both. Wheelchair services, which would either be occupational therapy or physiotherapy, depending on the service. And if there is a spinal injury unit, a spinal injury nurse, a liaison or outreach nurse. Thank you.
Barney, did you want to come in?
Sorry, yeah, it was going to be a slightly different issue, so I took my hand down, Jack.
Okay, sorry, Barney.
I would like to ask something when we've been through the, this discussion of the details of the MDT.
Yeah, sure. Jackie, and then Susie.
I think for the surgical MDT, it's quite important that we get some community involvement in there, because they're going to be the people who are caring for the patient when they go home. And I think that's what gets missed a lot. It's focused on in the surgical team about what happens within the hospital setting, but where a lot of the surgery falls down is when the patient gets home, it's not followed through, or the right care is not in place. So we do need either the kind of discharge liaison person or somebody that represents the home environment to be involved right from the beginning.
Thanks, Jackie. And Susie?
I was just thinking about smoking cessation team and the social workers. Because I mean, they take from the social workers, they take a major part in dealing with this. If they need different things at home to change their lifestyle.
Thanks, Susie. Absolutely. Aisha.
Sorry, just one more to add. The bladder and bowel team, or the continence service, whatever it's called in the area.
Oh, sorry, my screen froze. I think it's me though.
Did you catch that?
I didn't,
yes.
But did everybody else?
I did, yes,
yeah,
yes.
Yeah, that's the main thing. Barney, do you want to come in now?
Thank you. I've really been listening to this fascinating discussion and wondering whether, if everything is done properly, how that affects the number of patients who, quotes, should be referred for surgical reconstruction. It's very difficult to get a handle on how many people are getting surgical reconstruction at the moment, but it looks like 50 a year across England, maybe less. And it's really important to us to know whether that's likely to be the number who should be getting surgical reconstruction a year when all these wonderful things are in place, or whether it might be 200 a year because we've got a better pathway, and yes, all those things are being done, but we're actually getting more people into the surgeons, and the surgeons have the capacity, leaving aside the capacity issues at the moment.
Jackie.
I would say, Barney, that it's an underrepresentation of the people that need surgery, because for so many years tissue viability nurses have tried to get patients referred for surgery and have had no success. That it's now seen as such a difficult task. You have to be quite desperate to refer a patient for surgery.
Oh, you're on mute, Barney.
Does anybody else have any feeling about that? Because
I would agree with Jackie in that the patients that we tend to refer for plastic surgeries are the patients that offer surgical reconstruction, offer plastic surgery opinion. They are the patients that we are kind of desperate, and it's kind of last ditch attempts, which is not the right way of doing it. Really, we should be getting there early rather than waiting till it's the last thing that we consider. And I think half the time it's just we want to suggest it or look for some support to see if anybody else has got a better opinion than what we're currently doing.
okay, thank you.
Aisha.
I think it's difficult to quantify. I would, in my area, just my area, I would like to say maybe 1 a month. So that might be 12 a year. But it's very difficult because if there is a robust screening process, which would consider a person for surgery or for conventional dressings, I would often think it would be the younger people, and that's not because I'm ageist, it's because they're more likely to respond from the surgery and the adherence. But again, it's quantifying that age. I would look at cohorts of people, maybe considering spinal injury patients and their information given when they have spinal injuries. Their rehab afterwards is really particular. I would maybe consider groups of patients with MS, and there might be groups of patients where I would say they might be more suitable, but I think it's really quite difficult to quantify.
Nikki.
I think it is what Andy said, is that it is a last ditch attempt. You try everything else possible because it is such a hard process, and you have to be able to demonstrate that you've tried everything, otherwise the surgeons won't accept the patient anyway. And then when you do get a patient in there, they ask you why you didn't come sooner. But actually it's such a difficult process, and often it appears to me that it's not until we enter a crisis situation or we get to a sepsis situation, or you have to threaten sepsis, that you actually get somebody admitted, particularly when we're in this state that we're in at the moment of Opal 4 nearly every single day. That to get somebody in, you have to literally say to a GP, you need to admit this patient because they're going to get sepsis, or their markers are really high and they're on the verge of sepsis. So, you know, I think it is a last ditch attempt.
But I assume, Nikki, that's because of the fact that there's no commissioned service. Because if you did have,
there is in Cornwall we do have a pathway and we do have a policy, but trying to get and which the surgeons have agreed on. So the medics have agreed it, the surgeons have agreed it, the orthopedics have agreed it. But actually, when you admit somebody under the pathway, they argue about it in A&E as to who should take the patient. And like I say, I've actually been in A&E with a patient standing by their side where the orthopedic surgeon has accepted, the medic has seen them, and then I've thought, right, I'm on the way now. They're about to be admitted. They're about to have their urgent MRI. They're going to get sorted this weekend. And then I've suddenly got a phone call from the wife to say we're on our way home. And I've had to start all over again on the Monday to say what happened, why did you send them home, you accepted the patient, all of this, and then end up well, you came in the wrong way. You should have come through a fracture clinic. You should have come through an orthopedic clinic. And and then had to get a patient seen in orthopedic outpatients where they couldn't get on the trolley. So it was a nightmare getting them with a hoist onto the trolley so that they could be seen for bilateral ischial pressure ulcers. And it just so happened that because we have outreach or in-reach plastics, and it just so happens there was a plastic surgeon on site. So we then had the medics, the orthopedics, plastics all reviewing this patient at the same time with me there, and he got admitted that day. But that took me 4 or 5 days with the patient going home to do that, despite the fact they've got a pressure ulcer reconstruction for policy, which has all been agreed, and they were sent home.
But I don't understand. So why do you think that is? Is that why are they behaving like that if you have a policy in place?
Because I don't think they want to, not one person wants to take that responsibility in terms of that, or they've agreed it, but actually when it comes into principle, they're not abiding by it. And I really don't know why they're not abiding by it. Because they've all approved it, so I don't know why.
So it's not to do with lack of bed space?
No.
Surgical theatres?
No. They just, when it came to it, they were arguing about who was going to take overall responsibility. And the orthopedics were willing to do the operation, but the medic didn't want to take medical responsibility.
Barney, you wanted to come in, then Jackie, and I'm aware we're in our break time, so this is obviously a really useful discussion. I don't want to stymie it, but we've been sitting down for a long time. Given that we're talking about pressure ulcers, I think we should probably have a bit of time to move around. So, Jackie, bring you in, Barney, and then I suggest we stop for a short break.
I just wanted to, whether it was worth feeding back what we've been told by at least some surgeons, which is that these are very unattractive patients unless there is a dedicated provision for this particular form of surgery, because they stay in hospital so long.
Yeah, that's my point was going to be, I think they're seen as bed blockers, and I don't think they're an attractive funding source. So they block beds for patients who've got a very clear or distinct HRG, and these patients don't really sit anywhere. The hospital often doesn't have a contract for them. They slid in under all sorts of other things. There's no clear delineation about where that financial responsibility sits, and it takes away from other areas of what they perceive they should be doing and what they're contracted to do.
Nikki, you wanted to come in?
Yeah, I mean, the only thing, obviously, from the experience I've had, they get the patients out as soon as they've basically been surgically debrided. They and they come home, and then they're looked after by us, unless obviously they go for that surgical plastic surgeons. But this is when the orthopedic surgeon has done, we've managed to get them to do the debridement. They do come home as soon as they're which on this particular patient was only a couple of days, and he was at home. He didn't want reconstruction, he just wanted surgical debridement. But what I've managed to do because of that patient is I've managed to build a better relationship with microbiology and the orthopedic surgeon. And I'm in regular contact, and this patient has now almost healed. And without the plastics, it's taken a long time, but he didn't want plastics. So they didn't want to operate initially because he wouldn't have plastics. So I've been sending them updates of the photos so that they know that what they've done has actually made a huge impact on his life, and he is healing. So it is looking about all of those patients individually as well.